Hello everyone. So in the last session we read till syndrome of inappropriate antidiuretic hormone secretion. We read this pathology first. This topic. Now is 12:42. So our 30-minute session will be okay. This 18 minutes plus 12 minutes till 1:12. So let's start. Primary polydipsia and diabetes insipidus, characterized by the production of large amount of dilute urine, plus or minus thirst, urine specific gravity less than 1.006, urine osmolality usually less than 300 milliosmol per kg. Central DI may be transient if damage is below hypothalamic median eminence or in the posterior pituitary. ADH in hypothalamus can be still secreted systemically via portal capillaries in median eminence. Okay. Primary polydipsia and diabetes insipidus, characterized by production of large amount of dilute urine. Okay. Plus or minus thrust, urine specific gravity less than 1.006, urine osmolarity less than 300. Central DI may be transient, okay, if damage is below hypothalamic median eminence or in the posterior pituitary. ADH in hypothalamus can still be secreted systematically via portal capillaries in median eminence. Okay, got it. Now we have primary polydipsia, central DI, nephrogenic DI. We can study it as a differential diagnosis. We'll see definition, causes, serum osmolarity, ADH level, water restriction, desmopressin administration, treatment. Okay. Primary polydipsia, excess in water. Psychiatric illness, causes, definition is excess water intake. Okay. In which condition it can be psychiatric illness, hypothalamic lesion affecting thirst center, hypothalamic lesion affecting thirst center. Serum osmolality decreases. Yes, it makes sense because we are consuming more water, and we have read in the earlier sessions how sodium gets lost from the body, so that is the reason most likely to less osmolality. ADH level decrease or normal. Okay, understandable. Water restriction, significant increase in urine osmolality, more than 700 milliosmol per kg. Desmopressin administration, no. Treatment, water restrictions. Central DI, decrease antidiuretic hormone release. Idiopathic can be brain injury such as trauma, hypoxia, tumor, surgery, infiltrative disease. Serum osmolarity increases. Okay. ADH level decreases. Okay. No change or slightly increase in urine urine osmolality. Desmopressin administration significant increase in urine osmolality, more than 50%. Treatment desmopressin. In nephrogenic DI, ADH resistance, hereditary ADH receptor mutation, drugs that is lithium D-mecyclosine, hypocalcemia, serum osmolality increases, ADH level normal or increases, water restrictions, no change or slightly increase in urine osmolality, desmopressin administration, minimal change in urine osmolality, manage the underlying cause, low solute diet, SCTZ, amyloride, indomethacin. Okay. Okay, we are understanding this, we know this concept, but there are still some things that we are not able to connect and make a conceptual understanding, so it will stay with us forever. But that's what we are here. We are going to read, connect all the points and build our conceptual understanding, test ourselves by solving questions and looking at real patient at our internship, at our workplace. So that's how we are going to go ahead and build our knowledge base and clinical reasoning. No water intake for 2 to 3 hours followed by hourly measurement of urine volume and osmolality, as well as plasma sodium concentration and osmolality. No water intake for 2 to 3 hours followed by hourly measurements of urine volume and osmolality, as well as plasma sodium concentration and osmolality. Okay, got it. Desmopressin ADH analog is administered if serum osmolality is more than serum osmolality is more or less is more than 295 to 300 milliosmol per kg. Plasma sodium is more than 140 milli equivalent per liter, or urine osmolality does not increase despite increase in plasma osmolality. Okay. Hypopituitarism. Hypopituitarism. What we can understand from this term means there is less pituitary secretion. Okay, let's see if that is the case. Under secretion of pituitary hormone due to non-secreting pituitary adenoma, craniopharyngioma, Sheehan syndrome, ischemic infarct of pituitary following severe postpartum hemorrhage, pregnancy-induced pituitary growth, increased susceptibility to hypoperfusion, usually presents with failure to lactate, amenorrhea, cold intolerance, anterior pituitary hormones mainly affected. Empty cella syndrome, atrophy or compression of pituitary which lies in the sella turcica, often idiopathic, common in obese females, associated with idiopathic intracranial hypertension. Pituitary apoplexy, Sudden hemorrhage of pituitary gland, often in presence of existing pituitary adenoma. Usually presents with sudden onset severe headache, visual impairment, that is bitemporal anopia, diplopia due to cranial nerve 3 palsy, features of hypopituitarism, brain injury, radiation. Treatment include hormone replacement therapy such as glucocorticoid, thyroxine, sex steroid, human growth hormone. Got it. Next, acromegaly. Excess growth hormone in adults, typically caused by pituitary adenoma. Yes, that was by mistake. Excess growth hormone in adults, typically caused by pituitary adenoma. Findings: large tongue with deep furrows. Frontal bossing, coarsening of facial features with aging. Deep voice, diaphoresis, excessive sweating, hypertrophic arthropathy, impaired glucose tolerance, insulin resistance, hypertension, left ventricular hypertrophy, HFpEF. Most common cause of death. Increased growth hormone in children leads to gigantism, increased linear bone growth due to unfused epiphysis. Diagnosis of acromegaly: increased serum IGF-1, failure to suppress serum growth hormone. Following oral glucose tolerance test, pituitary mass seen on MRI. Okay. Treatment: pituitary adenoma resection. If not cured, treat with octreotide, somatostatin analog, trivisument, growth hormone receptor antagonist, or dopamine antagonist, that is cabergoline. Okay. Next, hypothyroidism versus hyperthyroidism. Hypothyroidism, hyperthyroidism. Metabolic, skin and hair, ocular, gastrointestinal, musculoskeletal, reproductive, neuropsychiatric, cardiovascular labs. Let's start with metabolic. In hypothyroidism, cold intolerance, decreased sweating, weight gain, decreased metabolism rate leads to decreased calorogenesis, hyponatremia, decreased water clearance. Opposite in hyperthyroidism, heat tolerance, heat intolerance, increased sweating, weight loss, increased synthesis of sodium, potassium ATPase, increases the basic metabolism rate, increases calorogenesis. Skin hair in hypo, dry, cool skin due to less blood flow, coarse glitter hair, diffuse alopecia, brittle nails, puffy faces, generalized non-pitting edema, mixed edema due to increased CAG in intestinal spaces, increased osmotic pressure leads to water retention. In hyperthyroidism, warm, moist skin due to vasodilation, fine hair, oncholysis, a pretibial myxedema in Graves' disease. Okay. Warm, moist due to vasodilation, fine hair, oncholysis, pretibial edema in Graves' disease. Okay, let's see. This is a Graves' disease. A oncholysis. This is oncholysis. Okay, this is not oncholysis. Onycholysis. That's how it spells. Ocular preorbital edema. In ocular preorbital edema, in in hypo it's preorbital edema. In hyper ophthalmopathy in Graves' disease, including periorbital edema, exophthalmos, lead lag retraction, increased sympathetic stimulation of superior tarsal muscle. Okay. Ophthalmopathy in Graves' disease, including periorbital edema, exophthalmos, lead lag retraction, increased sympathetic stimulation of superior tarsal muscle. Okay. Now GI. In hypo, constipation because decrease in GI motility, decrease appetite. In hyperdefecation, diarrhea, increase GI motility, increase appetite. Okay. Musculoskeletal, hypothyroid myopathy, proximal muscle weakness, increased CK, creatinine kinase, carpal tunnel syndrome, myoedema, small lump rising on surface of muscle when struck with hammer. Okay. Thyrotoxic myopathy, proximal weakness, normal. Okay, here it's normal ck, in hypo it's increase in ck. Osteoporosis, increased fracture rate. T3 directly stimulate bone resorption. Yes, we have studied this earlier in earlier sessions. We have to remember all the points, then correlate, build a conceptual understanding, must be able to recollect uh, while seeing patients, while solving MCQs, that clinical reasoning, that mental sharpness has to be there. It will come by reading, building concept, by practicing questions, looking at patient clinical reasoning. This will develop, and at the end, of course, our intellect, our day-to-day routine, everything will be affecting how our cognitive functions. Okay, next, reproductive abnormal uterine bleeding, decreased libido, infertility. In hyper abnormal uterine bleeding as well, gynecomastia, decreased libido, infertility. Almost in reproductive, if your thyroid is hypo or hyper, you are screwed here. Neuropsychiatric, hypoactivity, lethargy, fatigue, weakness, depressed mood, decreased reflexes, delayed or slow relaxing. Okay, this is for hypo. In hypo, everything becomes low. Hypoactivity, lethargy, fatigue, weakness, depressed mood, decreased reflexes. In hyperthyroidism, hyperactivity, restlessness, anxiety, insomnia, fine tremors due to increased beta adrenergic activity, increased reflexes, brisk. Cardiovascular, in hypothyroidism it will be bradycardia, dyspnea on exertion, decreased cardiac output due to. In hypo, this is in hyper, tachycardia, palpitation, dyspnea, arrhythmias, that is arterial fibrillation, chest pain, systolic hypertension due to increased number and sensitivity of beta adrenergic receptor, increased expression of cardiac sarcolemmal ATPase, and decreased expression of phospholamban lab, increased TSH if primary, decreased free T3 and T4, hypercholesterolemia due to decreased LDL receptor expression, decreased TSH if primary, increased free T3 and T4, decreased LDL, HDL and total cholesterol. This is A, B, C. A and B we have seen, and this is periorbital edema in hypothyroidism. Okay, got it. Last 6 months, not last 6 months, last 6 minutes to end our session. Okay, let's read hypothyroidism disorders, and this will be most likely last. We have to hurry to complete all these disorders. First, Hashimoto's thyroiditis, also called as chronic autoimmune thyroiditis, most common cause hypothyroidism in iodine. Most common cause of hypothyroidism in iodine sufficient region associated with HLA-DR3 differs by ethnicity. Increased risk of primary thyroid lymphoma, typically diffuse large B cell lymphoma. Findings moderately enlarged non-tender thyroid may be preceded by transient hyperthyroid state. Uh, Hashimotoxicosis due to follicular rupture and thyroid hormone release. Serology positive for antithyroid peroxidase, antimicrosomal, and antithyroglobulin antibodies. Okay. Histology Hurthle cells. Okay, let's see. This is Hurthle cells. Lymphoid aggregates with germinal centers. B. Okay. Postpartum thyroiditis, mild self-limited variant of Hashimoto's thyroiditis, arising less than 1 year after delivery. Okay. Subacute granulomatous thyroiditis, also called as D. When thyroiditis, usually a self-limited disease, natural history, transient hyperthyroidism, euthyroid state, hypothyroidism, euthyroid state. Hyperthyroidism, euthyroid state, hypothyroidism, euthyroid state. Natural history, transient hyperthyroidism, euthyroid state, hypothyroidism, euthyroid state, often preceded by viral infection. Okay. Findings: increased ESR, jaw pain, very tender thyroid, D. When is associated with pain. When is associated with pain. Histology: granulomatous inflammation. Picture C. Got it. Riddle thyroiditis, also called as invasive fibrous thyroiditis, may occur as part of IgG4 related disease spectrum, that is autoimmune pancreatitis, retroperitoneal fibrosis, non-tender, non-infectious aortitis. Hypothyroidism occurs in one third of the patients. Sorry. Let's read again. Riddle thyroiditis, also called as invasive fibrous thyroiditis, may occur as a part of IgG4 related disease spectrum, that is autoimmune pancreatitis, retroorbital fibrosis, not retroorbital, retroperitoneal fibrosis. Non-infectious aortitis. Hypothyroidism occurs in one third of patients. Fibrosis may extend to local structures, that is trachea, esophagus, mimicking anaplastic carcinoma. Okay. Riddle's thyroiditis. Finding slowly enlarging hard rock-like fixed non-tender thyroid. Histology: thyroid replaced by fibrous tissue and inflammatory infiltrate. Option D. Congenital hypothyroidism, formerly called cretinism, most commonly caused by thyroid dysgenesis, abnormal thyroid gland developed, that is agenesis, hypoplasia, ectopy, or dysmorphogenesis, abnormal thyroid hormone synthesis, that is mutation in thyroid peroxidase, in iodine sufficient areas. Okay. Finding 6-piece pot belly pot bellied pale puffy faced child E with protruding umbilicus. Okay, where is the E? Okay, this is before treatment, after treatment. Puffy faced child E with protruding umbilicus, protuberant tongue, poor brain development. Okay, other causes of hypothyroidism, iodine deficiency, most common cause worldwide, typically present with goiter. Okay, that is G picture. Iodine excess, Wool-Chukoff effect. Drugs, amiodarone, lithium, non-thyroidal illness syndrome, also called as euthyroid 6 syndrome, decreased T3 with normal or decreased T4 and TSH critically in critically ill patients. Okay, so at exactly 1:12 we have ending our sessions with we have completed just now hypothyroidism. So in this session we started from primary polydipsia and diabetic insipidus. We read hypopituitarism, acromegaly, hypopituitarism versus hypothyroidism versus hyperthyroidism. Hypothyroidism, we saw the main diseases or main clinical presentations, differential diagnosis. In next session, we'll start from hyperthyroidism. See you all in the next session. Oh man, ठीक है.